We are live, sir.
Okay. So good evening, postgraduates, and welcome to this 59th episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. We boast of this PG program to be a postgraduate program with a difference because it tends to cover the uncovered aspects of other teaching programs, like we have a case presentations, journal clubs, OSCE presentations, and sometimes didactics on topics which are not really comprehensively available for you in a textbook at a go. In this 59th episode, we have a didactic lecture on fundus fluorescent angiography, which was a long question in one of the MS finals. As well as during your OSCEs and practical presentations, you might have certain plates of fluorescent angiography, which you might be expected to identify and make a clinical diagnosis. So this lecture would be presented by Dr. Jay Sheth, who is a faculty ophthalmologist, cornea retina specialist at Shantilal Sanghvi Eye Institute, Vadala, Mumbai. My special thanks also goes to my dear friend, Dr. Debashish Das, who is a consultant vitreoretina and uveitis specialist at Sunetra Family Eye Care Center, Kolkata. Professor Dr. GVN Ramakumar, who is a consultant vitreoretinal surgeon at Sankara Eye Center, Indore. And our own friend from my city, Nagpur, Dr. Ashish Kambe, who is a consultant at Kingsway Hospital, Nagpur. I'm really thankful to all these discussants who have spared their valuable time for all my postgraduates. So without much ado, can I request Dr. Jay to share his screen?
Sure. At the onset, thank you very much, Dr. Prashant Bhavan-Kole and team AIOS ARC for inviting me to give this very interesting talk and very pertinent talk. So I hope my slides are visible.
Yeah, it's visible.
Okay. So hello everyone. Hi guys. So today I'll be giving my talk on fundus fluorescein angiography. So before moving on to this, we'll just go a little bit back in the history. So in this fluorescein angiography, it involves the injection of the sodium fluorescein dye that was first synthesized almost over 150 years back by Bayer in the year 1871. And the first reported case of a fluorescein angiography was performed by Novotny and Alvis, as we can see them in the picture. So they are there, and they had presented their work way back in 1961. And this is the image that they had presented. This was the first fluorescein angiography that was done. And this was published in the year 1961 in the journal Circulation. So then we go on to the principles of fluorescein angiography. So what exactly happens when we do an angiography test? And what is a fluorescein? What do we mean by that? So if we know any atom has got these multiple electrons, so E1 represents the electron at the ground level. And when it is stimulated by a blue light, it goes to the higher order state, that is E2. And when it comes back from the E2 to E1 level, it emits the green light. So this green light is getting absorbed by the filters from the machine, and that is what we see as fluorescein angiography in these patients. So fluorescein is nothing but the ability of absorbing light of a shorter wavelength and emitting light of a longer wavelength. And this is just a depiction of exactly what happens. So here we can see that this electron is in the inner orbit, and when it is stimulated by the blue light, it goes into the higher orbit. And once it comes back to its original orbit again, so this difference is being emitted as a green wavelength that is being captured by the machine, and that is how the fluorescein angiography works in these eyes. So now we look at the certain properties of the sodium fluorescein that is being injected in these patients. So sodium fluorescein is an orange-blue colored crystalline substance, and it is also known as triphenylmethane dye. It is a water-soluble dye which fluoresces at our normal blood pH of 7.2. Now 80% of this dye is bound to the plasma protein and 20% is freely mobile in our blood. So that is why we see a lot of extravasation that is happening from the choroidal circulation, that is the choriocapillaries, which are very fenestrated capillaries. The molecular weight of sodium fluorescein is 376 Daltons, The absorption range is in the blue wavelength, that is ranging from 465 to 490, and the emission range ranges from 520 to 530 nanometers. So that is a very smaller range for emission. So one very important thing to note is the fluorescein is very quickly metabolized and excreted by the kidneys. And it has a half-life of approximately only 30 minutes. So the toxicity is usually lasting for only a few hours once we do a fluorescein angiography in most of the patients. Unlike if we see an ICG dye, also the toxicity may last for 24 to 48 hours also. So this is the depiction just showing the absorption and the emission peak of this eye. And this is a very interesting depiction of a fluorescein angiography. So here what we see is the light bulb, and this is the eyeball. So when we inject the fluorescein dye, so it goes into the choroidal and the retinal blood circulation, and then the light is being emitted from the bulb that is there in the fluorescein angiography machine. And there is a barrier filter which allows only the blue light to go inside the eye. So once this goes inside the eye, it causes activation of this fluorescein dye. And because of that, the molecules, as we had discussed, they go into the higher state, and then again they come back to the lower state. So once they come back to the lower state again, they emit the green energy light. And there is another filter that is there over here, and this green energy is extracted, and the output is being processed as the fluorescein that we normally see. So this is just the excitation energy and the emitted energy for the fluorescein angiography that is being depicted in this picture. So what is the principle? So what is the normal behavior of these fluorescein in the eye? So normally, if we look at the morphology of the posterior segment, so there are three primary anatomical structures. So one is the choroidal vasculature. So the choroidal vasculature has fenestrated capillaries. So it freely leaks the fluorescein dye. The second barrier is a retinal pigment epithelium that is impermeable to the dye. And the third is a normal retinal vasculature that is also impermeable because of the presence of the blood retinal barrier. So what all equipment? So what all things do we need when we do a fluorescein angiography? So first we need a fundus camera. So that can be either a flash based or a SLO based. A fluorescein dye is usually available as 20% in 3 ml vial, and a standard emergency equipment will be needed in most of these patients, and it needs to be there because there can be certain life-threatening side effects that may occur when we are doing fluorescein angiography for these patients, which I will be discussing in the latter part of my talk. So what is the technique? So it is very important to explain the entire procedure of the fluorescein angiography to the patient. And we usually call the patient for at least 2 to 3 hours of fasting is needed because nausea and vomiting are the commonest side effects that are seen in 7 to 10% of these patients. So an empty stomach is primarily needed. A written informed consent is a must for all the patients. Now, prior to performing a fluorescein angiography, it is always better to dilate the pupil. Now, there are newer fundus cameras that are available that may capture these angiographies or the fundus photographs in a non-mydriatic state. But ideally, if we want to look at very peripheral lesions, it is best to get the pupils dilated. Now, after that, we have to check the vitals of the patient, including the blood pressure and the pulse and the sugars of the patient, because many of these patients will be diabetics. So it is important to know that all these parameters are under control. Then we keep the dye ready, and usually for these patients, a scalp needle is more than sufficient, and a syringe is needed to inject the dye. The fundus camera, as I mentioned, it can be either a flash-based camera or a SLO. It is very important to, because when we advise the patient to recheck the eye of the patient, whether it is the same patient or not, patient identification is very important. And then we position the patient properly and make sure that the camera is aligned properly. So once that is done, before we proceed with the actual angiography dye injection and the photographs, it is always good to take a normal color fundus photograph of the patient, because any angiographic interpretation needs to have the color fundus photograph side by side for the most accurate interpretation and detection of any lesion. After a color fundus photograph is taken, we take a red-free photo just to make sure that all the barrier filters are working properly. After that, we confirm the presence of the scalp vein into the proper location and the dye is injected. Now, as soon as we inject the dye, there is a timer that is there on the machine and that has to be started immediately because timing of this fluorescein dye angiography is very important to know if everything is physiological or are we dealing with any pathological delay of dye that is happening. Now, the first photograph, if the patients are usually young, we can start taking the photograph within the first 5 to 8 seconds. This is because in younger patients, the hemodynamic status is usually fast. The heart rate is usually fast. And for younger patients, it can be as high as 100 to 120. We are talking about, say, kids who have an ROP or kids who are 3 or 5-year-old who have other fibrovascular proliferative conditions in those patients. Now, for other elderly patients, usually the first photograph can be started to be taken from 8 to 10 seconds. After that, in the initial 1 minute, we can take photographs every 1 to 2 second interval just to make sure we do not miss any early part of the lesion. And the late phase photographs can be taken after almost 10 minutes later. So then we come to the normal phases of a fundus fluorescein angiography. So there are 6 phases. The first phase is also known as a pre-arterial or the choroidal phase that lasts from the first 8 to 12 seconds after the dye injection. This is followed by the arterial phase that begins 1 to 3 seconds after the choroidal phase. This is followed by the arteriovenous phase, the venous phase, which usually gets completed by 30 seconds. Then there's a recirculation phase. So once the dye fills all the veins completely, it gets recirculated into the blood, and this usually lasts for up to 3 to 5 minutes. And very late phase fluorescein angiographies are usually done from 10 to 15 minutes. So we will go through all these stages one by one now. So coming to the pre-arterial or the choroidal phase. So in this phase, there is filling of the dye into the choroidal circulation. That is the very primary thing. So now if we know the anatomy of the choroid, so the choroid has got multiple lobules. So here what we see, some lobules may get filled early and some lobules may get filled late. So when we talk about early and late, it is just a matter of few fraction of a seconds. But still, if we capture the image very nicely, we can see the segmental and patchy filling of the choroidal vasculature, including the watershed zone. So, and this visualization also depends upon the RPE pigmentation, because in our Indians, if we have a very heavily pigmented RPE, it may be difficult for us to visualize the choroidal phase in clarity. Now, most important thing to visualize in a choroidal phase is the cilio-retinal artery. Now, the cilio-retinal artery receives its circulation not from the retinal vasculature, but from the choroidal vasculature. So that is why it gets filled in the choroidal phase. And if there are any persistent filling defects, these conditions are pathological. So this is just one of the fundus fluorescein angiographies. And here we can see that the retinal vessels, they are all dark. So the dye has still not entered, but we can beautifully see the filling of the cilioretinal artery. And at the same time, if we look at the background flush, so this is the area where it is little hypo. So this part of the choroidal lobule is not filled. Whereas if we compare this, here there's a hyperfluorescence. So this part of the choroidal lobule has filled. So this is called as patchy, faint, irregular filling of the choroid. And if this is very significant, then we have to look at certain kinds of choroidal pathologies, like a choroiditis kind of a feature. So this is early stage is very important to identify these lesions. Next, we go on to the arterial phase, so which usually begins 1 to 2 seconds after the choroidal flush that is there. So here we can visualize the beautiful filling of the dye in the arteries, and at the same time, the veins that are thicker as compared to the arteries are completely dark. So the blood has not yet entered the venous circulation. So this is the classic arterial phase. Now, once the blood starts filling in the arteries, it goes to the retinal capillaries and subsequently it goes into the veins. Now, here, one very important point what I would like to bring about is to look at the arm to retina time. So, from the time we inject the dye to the time there is starting of filling of the retinal circulation. So, this is normally 10 to 15 seconds. And any increase in the arm to retina time more than 30 seconds can be pathological, including conditions like ocular ischemic syndrome. And at the same time, we also look at the arterial to venous transit time. So once the blood enters the arteries, within how much time is it entering the veins? So that transit time is usually 8 to 12 seconds. And if it is delayed by more than 15 seconds, so that means the blood is entering the arteries, but it is not entering the veins. So there is some kind of blockage that is happening at the level of the retinal veins, because of which we are able to see the pathology. So usually it is seen in patients with a retinal venous occlusion. So now this is the angiography that is showing the arteriovenous phase. And here one very important thing is we can see the complete filling of the retinal arteries. And at the same time, we can see the laminar flow, that is partial filling of the veins. So this is a laminar flow, what is depicted here, in which the center part is hypofluorescent and the peripheral part is hyper. So this is because the dye flows along the vessel wall first and then into the center. So that is why we see this laminar flow. And this is followed by the venous phase, in which the dye completely fills the veins also. So here, once in the venous phase, we can see that the veins appear to be darker as compared to the arteries. So when you are given this kind of dye to read in your OSCE, if you see the veins are darker, then this means it is a venous phase or a recirculation phase that is happening. Now, one very important thing here to note is if you want to see the foveal avascular zone, the arteriovenous phase is the most classic phase where you can evaluate this foveal avascular zone. So after the venous phase, so once the dye completely clears the veins, it keeps on recirculating in our normal blood. So this is called the recirculation phase. And in the recirculation phase also, the veins will appear darker as compared to the arteries. And this is followed by the late phase, in which there is a complete washout of the dye that is happening. So even the appearance of dye in the vein will slowly fade away. And other very important marker is we look at the optic disc. So here we can see the margin of the optic disc will appear more white, that is more hyperfluorescent. So this is because the dye starts getting collected along the walls of the optic disc. So this is what we call as staining. So these were the phases of the angiography. Now to just break it down and simplify it further, we will just go through the phases again. So this is the choroidal phase, where these are the dye molecules that are entering into the choroid. And here we can see filling of the cilioretinal artery. This is followed by the dye that is appearing beyond the beyond the choroidal arteries and into the retinal arteries, and the circulation can be seen in this phase. This is followed by the circulation of the dye amongst the capillary network plexus of the retina. That is the arteriovenous phase, and it starts appearing in the veins, which are depicted in the blue color. And this is followed by the venous phase, where the entire blood vessel veins of the retina are getting completely filled. And this is followed by the late phase, where we can see that the dye molecules are gradually reducing in number and it is slowly fading away. So this is a very simple depiction of the various phases of the fluorescein angiography. So then we go to the normal structure. So what do we see when we see a normal fluorescein angiography? So when we look at the normal macula, it appears darker in color as compared to the rest of the retina. Now, why does that happen? Now, that happens because there is a xanthophyll pigment presence at the macular area. So this causes masking of the background choroidal fluorescence. So that is why macula appears dark. The perifoveal arcade, that is the foveal avascular zone, are best seen during the arteriovenous and the venous phase, and free anastomosis of these capillaries can be seen around the macula. So this is just one fluorescein angiography that is depicting the normal foveal avascular zone. So here, this central hypo, it is because of the macular pigment that is there, and we can beautifully see the capillary plexuses that is there all around this thing. It's very important to make sure that this is a very proper circulation, and this FAZ usually ranges from 500 to 600 microns, and any focal enlargement of the foveal avascular zone is suggestive of a macular ischemia, and that could be one of the reasons for a non-improvement in the visual acuity in most of these eyes. Next, we come to the normal optic disc. So in a choroidal phase, the deeper vessels can be seen at the level of the normal lamina cribrosa. And along with that, in a very early phase, we can also see the epipapillary plexus and the radial peripapillary plexus. So we can see those small, finer vessels at the level of the optic disc in the choroidal phase. And in the late phase, the margins of the optic disc will appear hyper because of the staining that is happening from the peripapillary choroidal plexuses. Then we come to the adverse reactions that may happen when we undertake a fluorescein angiography. Now, so this adverse reaction can be seen in as many as 10 to 15% of the patients, and it can range from very mild reaction, and the most commonest would be the presence of nausea and vomiting during the procedure, and the development of yellowish staining of the urine and the skin for almost 24 to 48 hours post the procedure. So it is very important to tell the patient about this yellowish staining. Otherwise, you may have the patient coming back to you in an emergency or the subsequent day regarding these complaints. The other includes presence of mild paresthesia and giddiness that may happen. Now, slightly other significant reactions include allergic in the form of urticaria. The patient can have bronchospasm, angioedema, or even anaphylactic shock. So it is very important to ask a proper history of the patient, whether they have had an angiography done earlier and whether they have had any allergic reaction earlier. And at the same time, even the patient, if they have any history of any cardiovascular disorders, because the patient can develop adverse reactions, including syncope, arrhythmias, myocardial infarctions, pulmonary edema, or even cerebral ischemias. Now, at the same time, the patient may develop local reaction due to the dye, including necrosis of the skin, lymphangitis. The patient may develop seizures or even carpopedal spasms. Now, one very common thing that can happen is an extravasation of the dye if the intravenous needle is not placed properly. I have had patients in which a fluorescein dye was started, the timer was started, and my technician telling me, sir, there is there is a arm to retina time delay is there, the dye is not appearing. So the dye did not appear because of the delay in the circulation, but there was a delay because there was extravasation of the dye in the local tissue itself. So if you inject a dye and if you do not see the dye appearing in the FFA pictures within the first 15 to 20 seconds, the first thing what you should do is to look at the arm of the patient where the angiography is done, whether there is any localized swelling that is noted. So that will give you an idea whether there is a localized extravasation or not. If there is no extravasation, then immediately you should take the photograph of the opposite eye to see whether the circulation has started in the other eye or not. If it has started in the other eye, that means there's a definitive arm to retina delay that is happening in the pathological eye. So these are very finer points to note, and it is very important, at least for postgraduates, to actually be present and do fluorescein angiography to understand these finer nuances. And if the patient does develop all these localized extravasation, we usually advise them cold compressions, antihistaminics, and topical NSAID drops. And if the patient has had a history of nausea and vomiting, and if a angiography is definitely indicated, then in these patients we can give a small bolus dose of dye, maybe just a 2 ml of dye can be tried in these patients. So what are the indications? So when do we need to do angiography in these patients? So first is to make or confirm a diagnosis, because there are certain exudative macular lesions, like we may have patients with diabetic retinopathy whom we want to plan a focal laser. So in these patients, we do a fluorescein angiography to see where are the leakages and whether we can treat them. Next is to assess the prognosis of the patient. As I mentioned earlier, FAZ, the patient may have a suboptimal vision. The OCT may not show any swelling, so we do not know what is the cause of visual loss. So we do a fluorescein angiography. If there is presence of macular ischemia, you prognosticate to the patient that the loss of the vision is more related to the lack of circulation of the blood rather than an edema that is developing. Next is to determine the need of the treatment. Now, sometimes we may get confused in a patient whether the patient is having a severe NPDR or whether there are early proliferative diabetic retinopathy changes. So in these patients, we do a fluorescein angiography to confirm the presence of neovascularization, and then we look at the area or the extent of ischemia that is there, and maybe even do a targeted panretinal photocoagulation to that area, and at the same time to also monitor the progress of the disease. You may have a patient of proliferative diabetic retinopathy coming with bleeding again and again. In those patients, we do an angiography to look for the skip areas, look for the areas where there are non-perfusion, which may not have been lasered, and to treat those patients. Next is an oral FFA. So many of these times the patient may not tolerate a intravenous or not tolerate a very high dose. So the main indication to do an oral FFA is intolerance to IV fluorescein, or in very smaller children, like for ROP babies. If we do want to visualize the peripheral circulation, we do an oral fluorescein angiography. So here we usually mix 5 ml of the fluorescein dye with 20% dye with orange juice and give it to the baby. And photographs are usually started to be taken 30 minutes post giving this thing. So once we'll have looked at the normal fluorescein, what is it, how is it, then we come to the abnormal fluorescein patterns. And the two primary abnormal fluorescein patterns that I would like to cover today would be hyperfluorescence and hypofluorescence. Okay. So first we go to hyperfluorescence. Hyper means when we do a fluorescein angiography, any area that appears to have increased amount of fluorescence, that it appears more white in color, to put it in a very simple terminologies. Now there are four primary reasons why a hyperfluorescence may appear. First is because of a window defect. Second is because of a leakage. Third is because of a pooling of the dye, and fourth is because of staining. We will go through each of this one by one through a case-based scenario. So what is a window defect? So window defect is basically there is either decreased in the retinal pigment epithelial pigmentation amount, like if we see in Caucasian populations, so they have a more of a depigmented RPE, or there is a localized RPE defect. So when there is these kinds of changes that are happening, the background choroidal flush appears to be more hyper. So that creates more like a window defect. So this is usually seen in patients who have dry macular degeneration where there's an RPE atrophy happening, or even in patients with a full thickness macular because the retina is absent. So there's increased fluorescence that is happening. So this is just one of the cases where we can see the presence of a very small macular hole in the fundus in the fundus photograph. And when I do a fluorescein angiography in an early phase, if we look at the macular area, so there is hyperfluorescence over here. And in the late phases, the hyperfluorescence remains. But what is the differentiator for a window defect? So main thing in a window defect is the hyperfluorescence will appear in the early phase and it will stay in the same size. That is, the size will not increase, but the intensity will keep on reducing. Why does the intensity reduce? The intensity reduces because the dye is gradually recirculated and it goes out of the circulation. So the intensity keeps on reducing, but the size remains the same because the size of the defect remains the same. Next, we come to leakage. So what is the definition of a leakage? So leakage is nothing but a hyperfluorescence that increases in size, and along with that, it increases in intensity also with time. So this is the main differentiator. The size increases, intensity increases. And it is usually there because of neovascularization of the tissue, or it can be because of inflammations, vasculitis, or vascular or macular edemas. So this is one of the cases what I had of a diabetic retinopathy. So when we look at the fundus fluorescein angiography, there are multiple hard exudates on the fundus photo, and along with that, there are multiple microaneurysms that are scattered throughout. So when we look at the early phase, we can see these multiple white dots that are there, and in the mid phase, they are increasing in intensity, and in the late phase, they become very fuzzy. So they are increasing in size and intensity with fuzziness. Now, there is one more very classical thing what we can see in this lower part. So there is very early hyperfluorescence over here, which is also increasing in size and intensity. So this is actually a neovascularization that is happening in this patient. So this is neovascularization elsewhere. So the leakage can be there in diabetic patients either because of microaneurysms, which are usually pinpoint, or a neovascularization where we can actually see the new blood vessels that are there and that keeps on leaking the fluid and the dye. Now, this is one of the very classic OSCE things that you will get in your exams. So this is a case of an acute central serous chorioretinopathy where you just focus on this early, mid, and the late phase fluorescein. So in the early phase, this yellow arrow points to a pinpoint hyperfluorescent dot that is increasing in size and increasing in intensity. So this is a classic ink blot leak that is there in a patient of central serous chorioretinopathy. And here we can easily correlate with the serous macular detachment that is there on the OCT. Now, what is the other form of acute CSR leak that can be there? So this is the other form. So here in the early phase, we will see that classic point hyperfluorescence that increases in size, it increases in intensity in the mid phase and the late phase, and at the same time, it acquires a mushroom kind of configuration because of the protein difference that is there in the fluid. So it just goes up because of the gravity changes and it takes the configuration of the serous macular detachment. So this is the classic smokestack appearance of a acute CSR that is there. So these 2 points are very important. This is the classic ink blot leak of a CSR and this is a smokestack leak. So next we come to the pooling of the dye. So what do you mean by pool? Pool means it is getting collected in a localized anatomical space. So this pooling of the dye can happen either below the retinal pigment epithelium or below the neurosensory retina. So this is a very interesting case of a CSR where we can see both leakage and pooling happening. So when we look at the early phase and we look at this hyperspot, so this hyperspot is increasing in size and intensity in the mid and the late phase. So this is a leak that is happening. Now at the same time, these are the two other areas where we can see these hyperfluorescent areas. And in the mid phase and in the late phase, the size is remaining the same, but the intensity is increasing. That is, it is becoming more white in color. So why is the intensity increasing? The intensity is increasing because the dye is increasingly getting accumulated in the closed enclosed space. So the intensity increases, but as the space is very definitive, it cannot expand further. So the size remains the same in these eyes. Now, the last cause of hyperfluorescence is staining of the dye. Now, this is very easy. Staining is just a deposition of the fluorescent dye in the tissue for a prolonged period. So, a normal staining is usually seen at the margins of the optic disc, and an abnormal staining can be seen in a scar tissue. Like this is a classic example of a patient of a dry age-related macular degeneration. We can see multiple drusions on the fundus photograph. And when we see in the early phase, we can see early accumulation of the dye in the form of hyperfluorescence. And in the late phases, it is a very well-defined hyperfluorescence that is there that corresponds to the fundus photo. So this is staining of the dye that is happening in dry age-related macular degeneration corresponding to the drusions. So this is just a slide showing the various pathologies and in what condition can we see. So the accumulation of the dye can happen because of leakage across the blood retinal barrier. And if it is leakage across the inner blood retinal barrier, it may mean it is a microaneurysm or a retinal new blood vessel. If it is across the outer blood retinal barrier, that means there is a choroidal neovascular membrane that is happening. Then the accumulation of the dye can happen in pooling. So pooling can be either CSR when it is below the neurosensory retina, or it can be in a PED when it is below the retinal pigment epithelium, or a pooling of the dye can also happen in the cystoid spaces that is there in a CME, like a pseudophakic CME. That is where we see the petaloid appearance that is there. Now, accumulation of the dye can lead to staining. A normal staining is there, happens in the sclera, whereas abnormal staining happens in drusins, the vessel wall in case of ischemia, or even a scar tissue. Then the other cause of hyperfluorescence, it is because of increased transmission. And a normal increased transmission can happen in cases of hypopigmented RPE, like Caucasian populations, or even a post-VKH syndrome. And it can be abnormal in patients who have RPE atrophy. Now, this is just another pictorial depiction of what happens in case of hyperfluorescence, where there is either accumulation of the dye in the intraretinal area, or there is accumulation of these green dye molecules below the neurosensory retina in case of CSR, or below the PED in case of RPE, or there is a window defect that is happening. So next we come to the causes of hypofluorescence. So hypofluorescence is basically a reduction or an absence of a normal fluorescence that is happening. So there are two primary reasons why this can happen. It is can be either because of blockage that is happening or because of vascular filling defect. That is, the blood circulation is not happening in that particular location. Now, the blockage can be because of the media opacity. Suppose the patient is having a corneal opacity or a significant cataract. Itself, when we take a FFA in these patients, will not get clearer picture. Or the patient may have a vitreous hemorrhage. The blockage can be also be there because of blood at different levels. It can be pre-retinal, intraretinal, subretinal, or it can be because of pigmentary changes or some pigmentary abnormality that is happening at the level of the retinal pigment epithelium or the choroid. Now, this is a very interesting couple of cases that I have to share. So this is a patient of a proliferative diabetic retinopathy. And when we see the fundus photo of the patient, there is presence of this dense pre-retinal hemorrhage in this location. And along with that, there are certain other retinal hemorrhages also. So when we see the fluorescein angiography of this patient, so there's a large area of hypofluorescence that is there. So this, when we look at this hypofluorescence, it is very important to correlate with the fundus photo also to determine the level of the blood. And at the same time, it is very important to look at the blood vessel. So here, if we see, this is the optic disc, and we are not able to visualize the blood vessel from this location. So that means this blood is there at a pre-retinal level. So this is a pre-retinal hemorrhage that is there, that is masking the retinal blood vessel, including in this area. Now, at the same time, if I look at this area of hypofluorescence, I can beautifully demarcate the retinal blood vessels. If you can follow the tracing what I'm doing. And at the same time, in between, there are area of hypofluorescence. So this is a classic capillary non-perfusion that is happening. That is, a blood circulation is not happening in this area. Similarly, in even over here, we can see these areas of capillary non-perfusion happening. Now, at the same time, if I go to the lower photograph, this is also the case of a patient with a moderate NPDR changes. And here we can see these peripapillary hemorrhages that are there. Now, if I look at the fluorescein angiography of this patient, I can see patchy filling of these retinal vessels. So these bleeding is there more at the level of inner retina, and that is why I am able to see bit of the retinal circulation, but there is masking of the choroidal circulation. So very important to correlate clinical with the clinical fundus photo of these patients, exactly at what level the bleeding is there. Now, this is just another classic photo of a patient with a dense pre-retinal hemorrhage over here, and there's complete masking that is happening in this area. And at the same time, in the lower part also, we may get confused, whether this is a pre-retinal or subretinal. But here I see the fluorescein angiography. So here I can visualize this retinal blood circulation. So here I know that this hypofluorescence, that is this bleeding, is there behind the retinal circulation. So it is there at a subretinal bleeding is there in this location, whereas in the superior part, there is bleeding that is there at both the pre-retinal and subretinal location. Now, this is another classic example of a patient with a capillary non-perfusion in a patient of choroiditis. The next cause of hypofluorescence is filling defect, which we already have seen. That is because of non-perfusion that is happening. And it's a classic case of a branch retinal vein occlusion, in which in the early phase, we can see these hypofluorescent areas along the superior temporal arcade. And in the late phases, the hypofluorescent areas are still persistent. And at the same time, we can see mild staining of the retinal blood vessel that is happening, and that corresponds to the staining of the RVO. So this is just a pictorial depiction. So why do these hypo happens? The hypo happens because of masking of the normal dye. The masking can be because of the media opacities, because of either corneal or lenticular opacities, or because of a vitreous hemorrhage, or if there is a substance accumulation. The substance accumulation can be either blood at pre-retinal, intraretinal, or subretinal level, or it can be even because of melanin deposition and RPR chloride. The other causes of masking can be because of dense exudation, that is, even hard exudates can cause masking of this dye, or even dense fluid can cause. Or next cause is failure of the dye circulation. So if there's failure of the retinal blood circulation, normally seen in patients with retinal vein occlusions and retinal artery occlusions, or choroidal vessel closure may happen in patients of segmental microinfarcts, such as in patients with AION. It's just a pictorial depiction of causes of hypo. So here we can see the blood is there at the level of the sub-RPE and even at the level of subneurosensory retina. And if there is a thickened amount of pigmented RPE, it also causes masking in these patients. So what is autofluorescence? So autofluorescence is nothing but emission of the light in the yellow-green spectrum when illuminated by a blue light, even in the absence of a dye. So physiological autofluorescence can be seen in patients who have drusens. So that is why many times when we get confused with the presence of an optic disc drusens or a disc edema, we do an autofluorescence for these patients. And the other pathological can be seen in patients who have lipofuscin or other astrocytic hematomas. So what are the limitations of FFA? So it includes, there is very limited choroidal vascular details because there's a lot of extravasation of the dye that is happening. Additionally, the image quality may be poor if there are media opacities. Patients who have very high creatinine levels, they are contraindicated for doing an fluorescein angiography, and it is not possible for us to detect fluid. So the kind of OCT biomarkers like a fluid, whether it is presence or absence, will not be determined by fluorescein angiography. So just last few slides on certain recent advances in fluorescein angiography. So as we know, our normal fluorescein, whether it is a flash based or an SLO based, so in normal, the fundus photographs that we capture in this dye are usually of the posterior pole. So it usually covers a field of view of 30 to 50 degrees. So nowadays, the two most recent advances include a wide field angiography, where it captures the photo from 60 to 100 degrees, and an ultra wide field fluorescein angiography, where almost 110 to 220 degree of the field of view of these retina can be captured. So in the end, I'll just discuss a couple of cases to end my talk. This was just a 36-year-old male who came with blurriness of the vision in the right eye of almost 1.5 months duration. And this is the ultra wide field photography of the patient. So if we look, the disc, macula, everything appears to be fine. But when I look in the very far periphery, there is this lesion over here with a small amount of hemorrhage and a little bit of exudation that is there. So for these, when we do a normal fluorescein angiography, it is very likely that we may miss what is this lesion. So when we do an ultra wide field photo, so this is the early photograph, and we can see that early hyperfluorescent filling in this area of the lesion that is there. When we do a mid phase, there is increase in the amount of hyperfluorescence that is there. And in the late phases, there is increase in the size and increase in the intensity. So that means there is leakage that is happening from this lesion. So this is nothing but a classic case of vasoproliferative tumor of the retina that are usually seen in far periphery. And this is what we can see. And my last case, this is a very classic case of a proliferative diabetic retinopathy. And here these black lesions, what we can see infiltrate, it is vitreous hemorrhage. So clinically, when I saw this patient, I had a suspicion suspicion of two areas of neovascularization that are seen in these yellow spots. So I did a fluorescein angiography for the patient. So in this fluorescein angiography, in the early phase, we can see this area of hyperfluorescence in the lower quadrant and also in this early upper quadrant. And in the mid phase, there is increase in the size and the intensity, which increases further in the late phases. So this is a classic leakage that is happening from the neovascularization. At the same time, if we look at this hypofluorescent area, so there is complete masking of the background retinal and choroidal circulation. So that means that lesion is there in front of the retina. So that is a vitreous hemorrhage causing the masking. And at the same time, if we look in the far periphery, the blood vessels are seen very clearly, but there is hypofluorescence. So there is capillary filling defect in this area. So just to conclude, I think fundus fluorescein angiography remains a very pivotal diagnostic tool in ophthalmology and provides very invaluable insights into the retinal and choroidal vasculature. So recognizing the patterns of hyper and hypofluorescence is very critical, especially at the level of PG and henceforth. And while newer imaging techniques, so there are a lot of techniques like an OCT angiography where you do not do an injector dye, but you can see the circulation. So they definitely offer certain additional insights, but the fundamental principles of FFA continues still to be very much relevant and indispensable in our clinical practice. Thank you very much for your patient hearing.
Thank you, Jay, for so lucidly bringing out such a complex topic and making it so easy looking for the postgraduates.
Thank you.
Sincerely, I'm really indebted on behalf of postgraduates for wonderfully eliciting all the wonderful indications as well as bringing out the complications. So now I think the topic is open for discussion. You can unshare the screen
Yeah.
and we can have a small discussion. Before we start the discussion, there are a few questions in my mobile which the postgraduates have asked. One is, sir, can you elaborate on pre-choroidal phase? That's what he says. Can you just explain him once more, I believe, probably.
Okay. Okay.
Any
So
one of you can add. Initially, Jay can add and then others can compliment.
okay. We'll just go with the dye injection again. So as soon as we inject the dye in these patients, so that is actually the beginning of the entire angiography procedure. The pre-choroidal phase is the phase where the dye is just entering the choroidal circulation, but not entering into the retinal circulation. So if we look at the anatomy, we go back to the ophthalmic artery. So the blood circulation comes from the aorta, the carotids, it goes to the ophthalmic artery, it goes to the posterior ciliary, the choroidal arteries, and then it comes to the retinal circulation. So as the dye is ascending, when it initially appears into the ophthalmic artery, it goes into the choroidal circulation. So that is the phase of the pre-choroidal phase or the pre-arterial phase, what we call. Now, there are two very important pointers as I highlighted. First pointer is a patchy choroidal filling. That is, some parts of the choroid may get filled earlier as compared to the others. But even more important part is the filling of the cilioretinal artery. So the cilioretinal artery does not get its circulation from the retinal circulation, but it gets from the posterior ciliary circulation. So it gets filled first in the pre-choroidal phase, and subsequently we get the arterial blood circulation. Yeah, so I hope I was able to explain.
Yeah, I think so. Didi, you can add something about it? Didi,
I think Dr. Jay has explained it very beautifully in his lecture as well as now itself. I don't think you can add much to it.
okay. I think one important thing about this pre-choroidal phase, which Dr. Jai has spoken about, is that filling of a cilioretinal artery. So postgraduates, remember, once in a while, you might have a patient with a central retinal artery occlusion having a good vision. Why? Basically, it is courtesy cilioretinal artery, which is fed by the choroidal circulation. And that is why in few cases, and I think probably the incidence of cilioretinal artery is how much? Jay or Ashish, you can clarify for the sake of postgraduates. I think 10% have a
Yes,
cilioretinal
10%.
artery.
Less than 10%.
10% have. So these are the patients where you can have a good vision in spite of having ciliary. So that is the clinical implication of having a cilioretinal artery and why is it spared. Now, another question there is the postgraduate is asking, sir, the laminar flow in the blood vessel, is it staining of the vein? And why does it happen?
Sorry, I didn't get the question.
The question is slightly, he has framed it. Why
Okay.
is there a laminar staining of the blood vein? Is it a staining of the vessel? And why does it happen?
It is actually not staining of the blood vessel that is happening. So normally when we see the blood vessel circulation, so most of these RBCs and all are there in the central part of the blood vessel. So when as soon as the gush of the dye comes, it flows along the vessel wall first, and then it goes along the central part. So if we look at that mid phase, when we see, it is a matter of hardly capturing within 1 or 2 seconds. But it is very important to get it, if you want to see the exact laminar flow, it is very important to get it in that period.
Actually, the laminar, under normal circumstances, all the blood vessels in our body, including the eye, which we film, it has a laminar flow. The laminar flow means the blood vessels which are coming from the tributaries flow down the vessel along the course of these tributaries as it is coming into the circulation, and down the line they mix up to form a total web. So the laminar flow indicates that the dye is coming in from those tributaries into the circulation and then into the main vessels. It's natural for any blood circulation in our body,
Okay.
and that is what is depicted in the angiography.
Yeah, if I can add to it, I probably also, as Dr. Jay has said, in a blood vessel, the central part is usually the cells which are moving, that is the RBCs, WBCs, and they do not have the dye which is free to be means picked up by the reflected, means the dye is not available for means fluorescence. While the plasma has a dye which has the dye which is which fluoresces, and because the flow is along the wall, you feel as if the vessel wall is stained. In fact, it is not the staining of the vessel wall, it is the plasma, I should say, the flow of the plasma in the periphery, which looks to you as if it is staining of a vessel. It is not an actual staining. Staining, as Dr. Jay has already spoken, happens to a tissue. In fact, this is a plasma which is carrying a free fluorescence, which is fluorescing. And that is what exactly I think you probably our explanation might have sufficed you, hopefully, postgraduates. If you have anything, you can definitely ask it. One more question is, sir, what happens to autofluorescence structure when the dye passes through it?
It's a very interesting question. So the autofluorescence, that structure, it is going to be there. It is not going to get affected by that. Now, the most of the structures that are autofluorescent, commonly we see drusen. So there will be staining of the drusens that will be there. The staining may last for 30 to 60 minutes also. And once the dye gets washed out, so the fluorescein will clear away. But the autofluorescence, because of the pathological tissue that is there, will persist to remain in that anatomical location.
In fact, I was also foxed by this question.
It's a very interesting question. Absolutely interesting
I never
question.
thought over it, what would
It's
happen.
just the autofluorescence is so minute that you have to have different cameras to pick it up. So when we employ just a simple fundus camera, we may not pick up the autofluorescence itself. So when you do normal fluorescent dye, so like drusen, we can classify them whether they are staining or not staining. Means initially they can take up stain as well as later. Means they are hydrophilic. If they are not taking up stain initially, also like sir has showed that initially there was hypofluorescence and later there are staining, then they are hydrophobic druses. Similarly, in fundus autofluorescence, we can see that same drusen can have hyper autofluorescence or hypo autofluorescence, depending on lipofuscin content. The autofluorescence need different cameras. It is very minute, so we need different cameras.
Okay. So another one more question is, Sir, you said protein is responsible for smokestack. Then why is there a inverse smokestack?
Because the first we look at the gravity, like how much is the protein content. So most of these patients who have a smokestack appearance that is there, so because of the gravity, the heavier fluid gets collected at the bottom part, and the dye that is there, it goes in the upper portion where there is more amount of dynamic circulation that is happening. So that is why you see it is smokestack appearance in that regards.
He is asking ki if there is because of protein movement smokestack, why the inverse smokestack then?
The inverse smokestack, I think it will be because of the differentiator in the protein content and also the position of the patient also. So sometimes what happens is there may be accumulation of the protein. So many of these patients may have very long standing CSR tissue. So they would have fibrinaceous deposition that is happening. So suppose if we have a very round cavity space that is there, and if you have a fibrinous deposition, say in the upper portion that is there, so there will not, the dye will not have much space to actually go up in that location. So there will be more of staining that is happening that corresponds to the fibrin, whereas there will be more of fluid accumulated dye in the lower part of the serous macular detachment. So that is why the dye that is bound to the proteinaceous content, it comes with gravity in the lower part because anatomically there is not much space for it to go up because of the presence of the fibrin.
Yeah, great. Ashish or Debashish, interesting
Uh,
question the postgraduates are
yeah,
Very
asking.
yeah, yeah. I'm not very sure about this part.
Okay. Ashish, you have something to highlight on this particular question?
No, sir. Even this is a good learning for me too.
Okay, great. So one more question is, sir, in case one, what is that vasoproliferative tumor? Is it a melanoma or what is it? How do we differentiate? Probably.
No, so it is a vasoproliferative. So the vasoproliferative tumor is a distinct entity in itself, and it arises from the retinal circulation. So it is not a melanoma. Melanoma arises from the choroid. So usually for all these patients, we do a multimodal imaging, including a B scan, and we also do a CT scan to look for other pathologies. Melanomas are usually not seen in so far periphery. And melanomas will, when we do a fluorescein angiography, we may see more of blocking of the dye that is happening because of the increased amount of pigmentation that is happening. So this is more related to the retinal circulation that is there. I actually had put post, so the patient underwent triple freeze cryo, and I had post-operative images, also follow-up images of the patient, which unfortunately I did not put in my presentation. I can show them in case if it may interest them.
I think it's a good question as well. I think right now these are the only questions. Now we are open for discussion. The discussion. Debashish, you are a senior VR surgeon. You can add or something you think which will be essential
Uh,
for the postgraduate understanding.
I have a few points. First of all, I'd like to thank Dr. Jay for a very lucid presentation for the postgraduates. It's definitely a great one. I have loved it.
Thank you.
First of all, I'd like to say and highlight this sodium fluorescent dye is an absolutely inert dye, and there is a lot of tussle between the physician, particularly the nephrologist and the ophthalmologist, whether an angiography can be done or cannot be done, depending on particularly these diabetic patients with compromised kidney functioning. And there is a debate whether at what stages these dye can be pushed in these patients. Let me answer because we have gone through the nephrologist seminars also on this matter, that sodium fluorescence is not at all contraindicated in any of these chronic kidney disorder patients because the sodium fluorescence is an absolutely inert dye. What might have happened, the excretion by the kidney, which might be delayed for a few more hours, that is all that the patient can bother, but otherwise it will not cause any dysfunction of the kidney per se, even in a compromised state. That I should mention in this gathering. Number three, the third point is usually we do a skin testing of the sodium fluorescent you are going to inject into the vein such that to rule out whether the patient is allergic to this sodium fluorescent. If the skin testing shows a allergic reaction, we should avoid the fluorescein angiography test for that patients. I had a few patients which has shown allergic skin test and we deferred FFA for that patient for that time being. The fourth point is Dr. Jay initially said at one point that during IV there is a delayed skin to arm to eye IV transmission of the dye, and then you realize there is an extravasation. Whenever you use a sodium fluorescent dye into the IV, first of all, you should use a scalp vein set such that you can see the blood into the scalp vein set, then only you will push, number one. And number two, while pushing, we should note the veins around whether there is an extravasation, not during the time of the fluid going or not going into the eye that is already delayed. So immediately we have to stop if there is an extravasation. And my fifth point will be that FFA, the indications are gradually reducing over time. I'll give you a very small example. The CNVM itself, these CNVM lesions, once upon a time, we used to classify them as per the FFA pictures like lacy pattern, and then the how they are interconnected or they are not interconnected before the pre-OCT times. After the OCT came up, we are more dependent on an OCT instead of an FFA for these lesions. We stopped doing FFA for these CNVM, typical CNVM lesions anymore. I think these are the few points which we should keep in mind during our
Great.
situation. Yeah.
Thank you, Devashish. Wonderful few points. Can I request Jay to just share that vasoproliferative pre-treatment, post-treatment for the sake of postgraduates? They would be excited
Yeah,
to see how it is treated. So
yeah,
it must be PSCR, what we call it. Just
yeah,
tell them what that disease means.
yeah. So I think, are they visible? Yeah. So this is that ultra wide field photography of the patient. So this is so there are two distinct ends. So this something called peripheral hemorrhagic exudative retinopathy. So that is more related to a peripheral polypoidal choroidal vasculopathy. This is a vasoproliferative tumor. So this is the images that we had seen, and this is like a tumor that is arising from the retina. So this actually needs a triple freeze cryotherapy. So this is the pre-op fundus photo that I have. Now, immediately next day photo, we can see all these yellow marks that are there. So these are all the cryotherapy marks for the tumor that is there. And almost 3 months later, this is the thing. So here we see the almost completely the tumor has regressed. And we can now even visualize the choroidal circulation. These are the vortex veins, and the choroidal veins can be visualized in this area. And this atrophy that is happening in this area. So I have not done a repeat fluorescein for the patient, wasn't indicated at present, but we just these are just the serial follow-up of this patient, just for uh, discussion. I mean, this little different case, what the postgraduates may find quite interesting.
Thank you, Jay, for having such a wonderful case. In fact, but in such cases, it's not uncommon that the lesion here appears and then circumferentially it can
Correct,
have it at a later period over there.
correct.
Now, can I request Ashish for a few of his comments over the overall presentations and what he feels the postgraduate should additionally know?
So it's a wonderful presentation. Thank you, Jai sir.
Thank you.
Uh, just few things because when I was postgraduate, I was asked about them. Like when cystoid macular edema is there, usually now we depend more on OCT. But if FFA, we used to classify them as petaloid and honeycomb. So how to differentiate it and what is the reason for that particular appearance? Why petaloid looks like petaloid? Why honeycomb look like honeycomb? So that was asked. Um, it's- so
Can you explain it for the sake of postgraduates, since you have initiated that?
okay, sir. Suppose the retina is supposed to be flat like this, without any fovea and macula. The fibers of outer plexiform layer would be like this. So if I look from here, it would be dot 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 kind of thing when I look and first. But retina is not like that. Because of the development of retina, the retina get like this. So the inner part of the retina move outwards, the outer part of the retina move inwards. So these fibers are not parallel. These becomes like this. So when the edema happens in this layer, which is called as Henle's layer, it looks like a petaloid. But when edema happens in another layer, which is away from that, which is still parallel, it look like honeycomb. This I understand more better when I did fellowship actually, and but this was asked in my PG. I was supposed to know that. The second thing I was supposed to know that was how to classify CNVM when we call them occult, when we call them classic, and again, these concepts are not much important nowadays because we solely means we mostly dependent on OCT to classify them. Uh, Earlier, when there was a PDT treatment, then this classification made more sense. But now, since any CNVM can respond very well to anti-VEGF, so we are not very much eager to classify them into occult and classic. But when we do FFA, still in some studies, most of the studies, we still classify them as whether they are occult, predominantly classic or classic. So this thing is also important to know for postgraduate, I feel.
And also based on that location also, where are they?
Location also.
Yeah.
Location.
This is what is expected from them. So remember, occult means where you cannot make out the features of it classically. There are indirect features of fluorescent angiography which help you in making a diagnosis. Probably there is a neovascular complex. In a classic one, you will have a very well defined, what we should say, vascular complex, which looks like arteries and a network of vessels. So this is what I think one of you can highlight further about occult and semi-occult. I mean, is Jay, can you highlight it for the sake of postgraduates?
Yeah, so for a in a classic CNVM, it is more of a lacy filling of the vessel that happens. So you will get a particular vessel from which the network starts filling, and it starts in a very early phase itself, from the choroidal phase itself. So this is one of the indications for this thing, and it will increase in size and intensity. So there is a leakage that is happening. So something gets filled, increases in size and increases in intensity. So that is the classic CNVM. The other is an occult CNVM, in which there are two forms. So occult CNVM, it is an area of hyperfluorescence that appears in the mid phase kind of thing, and it stays there and increases in intensity. So it may have a kind of a LLUS, or a late leakage, or of an undetermined source. So sometimes you may not see any lesion in the initial angiographic images, but on a later stage, you will see kind of a leakage that is happening. So that is more of a occult form, because it is occult, because we do not know from where the leakage is happening. The classic form is the type form where we know exactly the vessel is getting filled and it is getting leaked. So these are classic AMD patterns that are seen. Now, as we discussed, so unfortunately now there is not much role of fluorescein angiography in determining of macular degenerations. It is primarily based on the OCT and more on OCT angiography also, to determine the type of network and the level of networks now.
One more question is there. How does the double circulation look, sir? You have any image of it to explain, Jay?
Double circulation, I do not.
Or you can, one of you can explain, Ashish or Debashish?
Not that I've heard of.
Ashish?
No, sir, I haven't. I'm not sure whether means it's double circulation. What
Tumor
will
and all, they might be
In
talking
the
about
tumors, this thing.
the tumor
Oh,
talk about. So you can explain them for the sake of how will it look.
So because in usually double circulation mostly seen in patients who have tumors. So there will be two things. So a normal fluorescein dye that is injected. So that comes to the retinal vasculature. So that is one of the circulations that is there. And in addition to that, so most of these tumors are from the choroid. They arise from the choroid. So the primary circulation to the tumor vasculature appears as a second circulation that arises from the choroidal. So you can see two circulations that is happening, very classically seen in patients with choroidal tumors, choroidal mass lesions and everything.
Okay, great. So
Retinal angiomatous proliferance can also have that double circulation. Type 3 CNV.
yeah, you can elaborate on it. This is a for a retina people you have spoken. Just elaborate it for the sake of postgraduate. Ashish, just because
Yes,
they
sir.
should
Yes, sir.
understand.
Yes, sir.
Yeah.
Yes, sir. I will. So in fundus fluorescence angiography, like we have two classification, classic and occult. So that classification is actually based because the RP, it acts like a barrier. So whatever below the RP, you cannot see well. So anything below the RP, if we cannot see well, means we cannot see in the initial phase. So that is mostly an occult CNV. But we don't say occult CNVM lie beneath the RP directly because we cannot see the level in FFA. But it's a very good guess that if it is not seen, then it is below the RP because RP is going to absorb everything. So similarly in OCT, we classify it whether it is below the RP, it is above the RP, or it is intraretinal. So something below the RP, we call it type 1 CNVM. Something above RP, we call it type 2 CNVM. Anything intraretinally, we call it type 3 CNVM, which is called as retinal angiomatous proliferance. So this there are different theories. Like Gas used to say that it comes from choroid and then get into the retina, where Yanuzi used to say that it is intraretinal, it comes intraretinal, then it goes to the choroid. So there is retinochoroidal anastomosis in this. So again, there is double circulation in late phases. And there are examples of both the theories being right. So anything inside the intraretinal neovascularization uh, is RAP. So since it has both the circulation, means retinal as well as choroidal, that can be seen in FFA.
So another example, postgraduates, if you are ever asked, the classic one you are expected to know is in a choroidal mass lesions where you have double circulation. And if you are graduating and if you answer RAP, you are going to get a gold medal.
So just one more, very interesting. So during my PGA, so I had learned, so there can be a CME that is present on an OCT without a leakage on a fluorescein angiography. So normally if we see CME, that is a pseudophakic CME, diabetic, it can be there. So there is only one condition where there is CME on OCT but no leak on fluorescein. So that is in cases of niacin deficiency. Niacin deficiency. So this is what I learned in my PG. Now, why does that happen? That happens because the niacin deficiency, it causes damage to the Muller cells. So it is a structural defect that is happening inside the retina, and that is why you see those cystoid spaces. Now, the if we just go back in my during into my entire talk, why does a leakage happen? A leakage happens when there is a damage to the blood retinal barrier. It is either at the level of the RPE or it is level at the level of the retinal circulation. In niacin, the blood retinal barrier is intact. That is why you see a CME on OCT, but on fluorescein it appears absolutely normal. So they know that that is, so this could be another gold medal question. And if any examiners are there, I think they might also consider asking this.
You have made me wiser. Definitely, I don't know this answer. Probably you have prevented me from looking a fool after 25 years of being in retina and not knowing it.
This is given in some remote corner in some remote book where I had read, and then I wanted to read more about it. That's why.
Correct, correct. Thank you. Debashish is also laughing. Probably he
I think
was
no one would have heard it, I guess.
I've never heard of it before.
Very good, good. So this is the advantage of postgraduate teaching program. You know, Debashish, I attend it
Absolutely.
regularly. And most of this
Absolutely.
time, it is these postgraduates who challenge you and make you read sometimes some of the things which you tend to forget or might not have read during your whole course
Ab-
of your post-graduation fellowships and practicing retina. Be it.
Absolutely. You are correct.
So anyone has any more comments before we wind up? We had a beautiful fantastic discussion over it. Devashish, you have something, some comments for that?
This is a fantastic evening. I'm grateful to you for keeping me in the discussion.
No, it's not for thanking. I said any comments for the sake of postgraduates. Otherwise, I
No,
will put off.
no, you can
Ashish,
wind up. Yeah, yeah.
Ashish, from your side?
No, sir, it was wonderful.
Yeah. So we are not going to pat each other's back. We are all here because of postgraduates and we are trying to do good for them.
Yeah,
So, Bolo Jay, any
so
comment?
just have two comments. So, for all the postgraduates, uh, reading a book is a completely different thing, but doing it is completely different. So, my suggestion is two. First is do the fluorescein angiography yourself to get to know the entire practical procedure, what you are doing in that, including all the phases of the angiography. And second and more important thing is to report the fluorescein angiography. Report it. If you continuously report at least one angiography in a day, then by the time you are ready for your post graduation exam, you are actually you will be very ready for that. Just one angiography in a day. Hypo, increasing in size, increasing in intensity. Just keep on doing that one per day, and you are going to master fluorescein angiography like anything. I know there are other technologies that are there, but I am very confident that FFA is here to stay for another 500 years.
You. Thank you. That's a very nice suggestion. Any and every investigation for that sake, postgraduates, remember you become conversant only if you see or come across those investigation and try to interpret. Don't read what is given on the reading. So just hold a plate, try to interpret for yourself. And if there is no teacher around you, then you go back to their findings. So any investigation for that sake, hold it, try to write it down in a typical way the book describes, and then you compare it what your teachers seniors have written it, and this is how you will keep on learning, and then you will be a gold you will be ready for a question on niacin probably, and carry away a gold medal. And thank Dr. Jayshed for wonderful elaboration of this fundus fluorescence angiography. So I think it's time for us to wind up. It's almost 20 minutes beyond 9. Thank you, Jay, for preparing and creating such a lucid and simple presentation for the postgraduates and making it so look easy. A difficult topic, frankly speaking. And of course, Ashish and Devashish for their wonderful inputs and helping out our postgraduates with their understanding of this difficult subject for them, apparently. It was difficult even for us. Even now, we know there are certain cases which really fox you even now. Be it. So, postgraduate, thank you once more. And on behalf of you, I thank all the discussants as well as the presenter today. We will be meeting on a coming Thursday again at 8 p.m. with something new. Till then, it's time for us to say bye-bye.
Bye.
Thank you once more, everyone.
Thank you. Thank you so much. Thank you, everyone.
Bye.
Bye. Thank you
Bye.
so